tell everybody that we're going to record this so that we can share it with other people who can't make it today. If you, Dr. Wilkes is willing to take questions as we go along, unless that gets too chaotic. So I'll monitor the chat room for questions. I'm looking at it now, and okay, I see there are a couple of questions there. Yeah, okay, that's good. I'll catch up on those later. And so if you have a question, you want to ask a question, you can go in the chat room, you can wave to me, or you can just raise, or you can go to the reactions at the bottom of the page and click on the raise hand sign. That will bring you to my attention. Okay, so we are delighted to have Dr. Stephen Wilkes with us today. Stephen is a family medicine physician at Suburban Hospital, specializing in palliative care and hospice. Upon graduating from Tel Aviv University Sackler School of Medicine in 1998, he completed his residency in family medicine and received board certification in family medicine in 2001. Dr. Wilkes has practiced family medicine for over 20 years and has since been board certified in hospice and palliative care after completing a hospice and palliative care fellowship in 2009. Palliative care physicians, as we will hear from him, provide specialized medical care for people living with serious illness. Doctors who specialize in palliative care, like Dr. Wilkes, focus on providing relief from symptoms and stress, offering care that is focused on improving quality of life for both the patient and the family of the patient. Palliative care is appropriate at any age and at any stage in a serious illness, and can be provided, and this is very important, can be provided along with curative treatment. So that's my little introduction for Dr. Wilkes. I also want to mention Kate McGrail, who's my contact at Suburban, who arranged for Dr. Wilkes to come today. Kate McGrail, we thank you very much, and it's great to work with you as a colleague and partner. Okay, let's. So we'll start now. So Dr. Wilkes, I'm going to hand over to you. I know you've got some slides, and Dr. Wilkes, I'll hand it over to you.
Okay, thanks. Just a little clarification of my medical background. It's true, I trained in family medicine and did that for a while, but since 2009, I've only been doing palliative medicine with some hospice along with that. But I think family medicine gave me a good background. All right, well, today I'll be talking about palliative medicine. You kind of touched on what it is, but I'll flesh that out some and how it can help. When you should think about it and how it's different from hospice, because there's a lot of confusion about it. I should say that I'm impressed there are people here. You're definitely a select group, because most people don't want to talk about this stuff. So you're all unique in that way. So I'll just start it off with a case. This was a recent case here at Suburban Hospital. A 62-year-old patient was admitted to the hospital receiving chemotherapy. And basically what happened was she was getting chemotherapy for colon cancer that spread in her belly, and it caused her intestines to get blocked. So she couldn't eat or drink, and that was causing her to vomit. So she came to the hospital. She was working full-time in the community, and she's had colon cancer for 3 years already, and was on an outpatient regimen. And unfortunately, when patients come to the hospital with this problem, we try to what we call treat them conservatively, meaning we just let them rest, give them IV fluids, and wait and hope, because it's not that uncommon for the intestines, the piping, so to speak, to just open up. And patients feel better, and they go home and they go back to their regular life. But unfortunately for this patient, we gave her a long time to rest, but her gut didn't open up. So what do? So palliative medicine, we were consulted, first because she was having difficult pain and nausea from this problem. So they asked us to help just with some of the symptoms that she was having, which, we do what our colleagues do. We use pain medicines and nausea medicines, but they'll ask us to help if they're having a difficult time, if the symptom management's tricky and they want someone, to provide, a consult level, some expertise. But beyond that, she had very difficult things to contemplate. Again, this was active 62-year-old working full-time, and now she's hospitalized, and basically she can't use her intestines anymore because the cancer has grown and now her intestines are blocked. So obviously this was very difficult news, and there were complicated things she now had to contemplate. So this is like a role for palliative medicine, because obviously a 62-year-old who comes into the hospital with pneumonia, you give them antibiotics, they get better, you go home, you don't have to call palliative medicine. Decision-making is pretty straightforward, but this is a complicated case because for her to go on in life, she can't eat or drink for the time being, for the coming months. She'll need a tube inserted into her stomach to drain her belly because it's blocked. And the fluid that our intestines make all the time, even if you're not eating and drinking, have to get out of your body some way. So she had to decide, do I want this tube coming out of my stomach and to go home getting IV nutrition because I can't eat and drink anymore? So that's pretty devastating, obviously. And we had several discussions about it. Also had to speak with her oncologist because her cancer's been spreading. What does this mean for her future? If the oncologist said, well, maybe with difficult chemotherapy, we get her another month, she might have a different answer than the one that I got from the oncologist, which was that, well, if she's a good responder, she may have a couple of years. So that helps us put these difficult decisions into context. So what did we do in palliative medicine? First, we were just using our skills of empathy because, we appreciate this is a difficult experience. So we have a social worker on our service that can help just provide support. We do that too as docs, but that's just part of what we do. We're not as good as our social work and chaplain colleagues. So we got our social worker and chaplain involved. The other difficult issue to consider, well, and I touched on this, is what does this new problem mean for her future? She was divorced, living alone. God forbid something happened, who would make decisions for her? She did not have an advance directive or identified decision maker. So that was something we ironed out during the hospital stay. And, unlike a lot of people, she was very receptive to sitting down and filling out an advance directive. That's not so common here in the hospital. And so she had the procedures done and she followed up with her oncologist. The only thing new was when she left with an outpatient palliative medicine team to help support her through, whatever happens next. So that's kind of an example of what we do. As Chris mentioned at the beginning, we're like an extra layer of support in patients with serious illness. It's not just a doc. In the perfect world, we'd have a big team of social workers, psychologists, chaplains, pharmacists, nurse practitioners, nurses, etc. But palliative medicine, it's very unique to the specific hospital, county, etc. Some areas it's more well established in the hospital, in the outpatient setting. For a while here, it was just Dr. Wiltz. Now I have a social worker and a nurse practitioner. So a palliative medicine team varies. I'll talk a little bit more about that later, but. So when do we get involved? Again, it's complex illness. The 50-year-old who comes in with a bad pneumonia, they'll get antibiotics and go home and go back to work. They don't need our help. It's more patients with complex illnesses. Sorry, my computer's acting a little funny here. So what's a complex illness? Those are medical illnesses that have difficult symptoms that are impeding, seriously your quality of life or daily function. Often when this occurs, it occurs not just in an organ in a person, it happens to the whole person. So it affects their personal life, their family life, potentially their spiritual life. So we try to look at everything. And one of the our most important resources we have is time. I mean, all of us, my colleagues, etc., understand that with complex illnesses, decisions are complicated, medical conditions are complicated, circumstances are complicated. So we actually spend more time than your so-called usual doc. Often, and sit with patients and often have family meetings as well. Not just the patient, but their loved ones in the hospital will come in or in an outpatient center when things are complicated. Family meetings, yes. The goal of palliative medicine is to help people do better. And sometimes that means tolerate their cancer therapy better. Sometimes it means tolerate symptoms of their illness better. Sometimes it's just emotional support to help them cope. And sometimes it's just help navigating the healthcare system. I live in this universe, but most people don't. So that's where social workers can help. A lot of times the patients we see have a lot of doctors involved, require complex medications, etc., need resources for home. So we work closely with social workers who help patients and families understand what resources are out there and how to take advantage of them.
Can I interrupt for a second,
Please.
Stephen?
Yeah.
There's a question here in the chat room from Evelyn Jacob, and she asks, how does a palliative care doctor get involved, i.e., who calls them into the case?
Yeah, that's a good question. So the answer, I think, depends where you practice and your institution and the unique culture there or in the outpatient world. I apologize, I'm inpatient focused. This is where I've been working, doing this for so long. But so for example, here in the hospital, it used to just be the doctors. And then, we in palliative medicine noted that the nurses see things that maybe the doctors don't. So we opened it up to nurse practitioners, nurses on the units to give us consults. We were going to open that up to social workers as well, because they see a lot also, but we're just too busy. So we put the kibosh on that. And sometimes families will ask. So that's how we get consulted here. In the outpatient world, it's really like any other doctor that because, we're a specialist, you need a referral, or that might depend on your unique insurance. But my anecdotal experience here in the hospital, that the outpatient palliative medicine practice needs a referral. But I guess you should probably check your insurance company to see how they deal with that sort of thing. With Medicare, you need a referral. Were there any follow-up questions to that, or?
Not at the moment. You're doing great.
Oh.
Keep going. Yep.
Okay. So again, a little repetitive, but just examples to flesh this out. So when would you consider palliative medicine? So sometimes it's patients with curable illnesses. So that might be a patient, for example, with throat cancer. You know, the treatment for that's very difficult, but luckily there's a light of high cure rates at the end of the tunnel. But we see a lot of patients here in the outpatient oncology practices, because the treatment for throat cancer can be very painful and difficult. See a lot of patients with chronic illness, you know, advancing heart disease, lung disease, kidney disease, or patients with dementia. You know, dementia is unfortunately a progressive illness, goes through many stages. So we may be asked to help sit with the family so they know what to expect over the coming years or months, depending on the circumstances, and strategies to deal with problems connected with dementia as it advances. So again, across the spectrum. Just put this slide here to, you know, because the truth is what we do is what a lot of docs do. A lot of internists and family doctors and my specialty colleagues. But what's different about palliative medicine is we see patients that are more complicated, that require more time, more consideration, more emotional or spiritual support, or tricky symptoms that our colleagues say, okay, I tried, I've done what I can do, but I think we need someone else to give us a second opinion. Is that clear?
Yeah.
Okay. All right. So I wanted to talk a little bit about advanced care planning, because this is something we end up doing quite a bit. You know, before I practiced medicine, but not that long ago, you know, medicine was very paternalistic, and physicians would kind of make the decisions for patients and families based on their expertise and, you know, basically their beliefs. But then in the 60s and 70s, you know, medical ethics started to change, and people started to demand say in their care, and, you know, not just defer to the, you know, the expertise or the, you know, the opinion of the doctor, because a lot of what we do in medicine is more than just technical medical treatments. You know, they're contextualized to unique circumstances, and, you know, sometimes treatments are difficult and patients might not want them. Sometimes they would, but they want to understand what it means to try. So over the last bunch of decades, medicine became much more of a team sport. And what grew out of this also was living wills, which I'm assuming this crowd knows what they are, but basically, you know, living wills are the forms you fill out that can speak for you, can communicate your values if, unfortunately, you lose the ability to do that, and you need to speak for yourself somehow. And living wills document your general beliefs and, you know, identify who the healthcare team should speak to if you can't talk. You know, the best.
You know, we often call those advanced directives.
Yes, right. And what's very important is to have a loved one who can help make decisions on your behalf. You know, someone who knows your values and
Right.
beliefs. Yeah.
Right.
So again, I'm assuming you guys know what this is, but the basic idea behind living wills, advanced directives, again, is to have your beliefs known beforehand. So when things get difficult, families know what to do. I can't tell you how common it is when we're in the hospital, and, you know, for understandable reasons, you know, the human condition. Families are scratching their heads saying, well, we never talked about this stuff, and I kind of have an idea. But again, this crowd's unique because statistically, probably around 90% of people don't want to really engage in this stuff very much. It is a select group. So those that do can take advantage of filling out an advance will.
Stephen, I have another question here from
Yes.
Shoma Brisso. Shoma asks, do you need referrals? And then she continues with the question, how long do you stay on palliative care?
Okay. So I will answer that in 1 second. One last point about advance directives or living wills is that you do not need a lawyer or a notary. You don't have to pay to get one done. You just need to print one. I'll have more information on that. And you need some witnesses, but the witness can be your neighbor. And the final note about directives is that, you know, I see patients who filled them out 20 years ago and things have changed since then. So it's just important to keep in mind that the directives reflect your values and position on things at a certain point in time. Obviously, things change and people feel differently, but just want to make that point. So back to the question. The question was,
do you need referrals? And then how long do you stay on palliative care?
Right. So referrals, I suspect, depends on the type of insurance you have. I say that just anecdotally. I'm not a health insurance expert, but the practice out here, we need to send referrals, just like some insurances require a referral to see some sort of subspecialist. So I think it's really going to depend on insurance. How long would someone be on palliative care? So I would rephrase the question because it's not really a status where your clinical circumstances change where you're on palliative care. I would think of palliative medicine as an extra layer of support for complex medical situations. So we work with our colleagues, with patients, again, who are hoping to cure. So for like the throat cancer patient I mentioned before, we might be involved for their pain and other difficult symptoms. And then once they're cured, after months, they can go back to living a regular life and probably won't need to see us again. Or until down the road when something else happens. That might be different with a patient and family, let's say with dementia. You know, Alzheimer's is the most common kind. You know, the average life expectancy is 9 years. So we may get involved at a certain stage and have meetings with family twice a year or 3 times a year, or more frequently as things get more complex down the road. But we're really an extra layer of support. You know, patients who see us still have primary care doc, still see their specialists, but we're involved for the complicated stuff. And the frequency of how often patients will see us will really just depend on the unique circumstances of their illness. Does that make sense?
Yep.
Okay. What else? So I just wanted to talk a little bit more about advance directives or living wills. There are different versions of them. I'm just mentioning a couple here, but there are several. One that I like is Prepare for Your Care, and you can get it free on the web. This is like a good example of how you can document your wishes. And this is an example, you know, today in your current health, you can see it highlighted there. What's important to you? Is your main goal all the way on the right to just really focus on comfort? Or is your main goal all the way on the left, to live as long as possible, no matter what the burdens of illness is? Or are you somewhere in the middle? I like this because it gives families some guidance. And, often they don't know. And there are some living wills that don't communicate anything about this. And frankly, it's hard to. I mean, living wills, it's another discussion. They're not perfect, because life's too complicated. The goal of a living will is really to convey it, to give direction, not to spell out, if I have this condition, this condition, this condition, this condition, because that's too complicated. But they do give loved ones some guidance. And what's nice about Prepare for Your Care is it enables you to communicate at least some about your values. And another page is, okay, well, the other page was when you're at any given time, but it lets you communicate your values. Let's say you're at the end of life. You might feel differently about the burdens of interventions when prognosis is limited. Some people want to avoid suffering at all costs. Others will suffer quite a bit if it means getting an extra month. So it helps, communicate some of that grayness that's often difficult to document.
We have another question for you,
Yes.
Stephen. This is from my wife, Gail. She says,
Yes.
how common is it for insurance or Medicare to deny coverage for palliative care?
That's an interesting question. I don't know this. I haven't seen any research on that. If it exists, I don't know. I can tell you that doing this for years, I can't recall it ever being denied. Yeah, it's a good question then.
Okay, thank you.
Yeah. Any other questions? I'd rather field questions and just read through slides. So I can go on.
Yeah, you're doing great. Yeah, keep going. And we'll interrupt you with questions as they come up.
Okay. Mentioned that before. For advanced directives, they're free. You don't need to pay anybody. One thing I would recommend, just anecdotally from my experience over the years, is filling it out with the healthcare professional, because directives talk about things like CPR, being on a respirator, getting fluids and things like that. And it's complicated. And, the forms aren't clear. Like I remember talking to one lawyer who said, I usually recommend IV fluids because it's sort of a way to respect somebody. And I understand that, because we feed people because we love them, and that's one of the ways we show affection. But, sometimes it's really a bad idea to give fluids, and it's not a way of being respectful. I won't get into the minutiae of that, but it just brought to my mind that, these are often complicated medical interventions that aren't so straightforward. And, I'll be honest, that's my own opinion. There may be lawyers here or other people who feel differently, but that's just what I've anecdotally found.
Yeah, no, thank you. There's a question here from Evelyn Jacob. She says, how often are living, and then I'll come back to another question from Hannah, but this question from Evelyn, how often are living wills actually followed by medical staff? I've heard that they are not always followed. How does one maximize the chances that a living will be followed?
Wow. Okay. That's a great question. So how often are they followed? I can't give a black and white statistic, but I'd say frequently they're used for guidance, but sometimes they are not followed. That's often very challenging for us clinicians because, you know, the directive is speaking for someone who can't speak. You know, who's the most vulnerable person in this circumstance? It's the patient who can no longer communicate their wishes. But the truth is, at the bedside, you know, often these issues come up in deeply emotional circumstances. So I don't think there are villains under these circumstances. There are families that are dealing with what's most important and dear to them in their lives, and they're trying to make very difficult decisions. They often don't want to lose their loved ones, and sometimes the will, we respect it, would end up in that. So it's often very difficult. Sometimes we put our foot down and it's okay, and sometimes we try to put our foot down and families get very upset. Just being honest of what it's like at the bedside. But I think the best way to have your will respected is to really have discussions with your family so they know what's important to you. You know, the directives, you can look at them, you probably scratch your head trying to figure out what do they really mean. They're not so black and white. They're definitely, they give us guidance and direction. Sometimes they apply black and white. Sometimes, a lot of the times it's like, well, sort of, maybe, you know, what do you know about your dad? You know, what do you think he'd really think if he were sitting here now? They don't solve every problem, but they help.
So Dr. Wilkes,
Yes.
Dr. Wilkes, is it true that some doctors have been sued for unlawfully prolonging life? In other words, to Evelyn's
Yes.
question, to okay, yeah.
Yes, I'm not a lawyer, but those suits are called wrongful life suits, where
Right.
patients are rescued against their preferences.
Right.
Those suits are very rare. I don't think doctors tend to worry about that. Frankly, they worry about the opposite.
Yeah.
Why didn't you do this for our loved one?
Yeah.
That's 99.999 more likely to be the circumstance. But
I agree. I agree. There's a question here, Dr. Wilkes, from Hannah. She says, but I think you're going to deal with this later when you come to your post slide, but she says, please discuss most forms and post forms are the same thing. My physician helped me fill it out and signed it. Will you discuss that down the road a little later on? Or do you want to do it now?
No, I could do that now. That's fine. I don't have a slide for that, but yes. So a MOLST stands for medical orders for life-sustaining therapy, MOLST. And that's what we use in Maryland. Other states have PULSE, which I think is physician orders.
Right.
But yeah, here in Maryland, we use MOLST. It was adopted, I forget when, maybe 7 years ago, 10 years ago, something like that. But basically, a MOLST are actually orders, just like it says in the title. Medical orders for life-sustaining therapy. So an advance directive is not an order. It's a document that expresses your wishes, communicates how you might want to be treated, but it's not an order in the chart where, you know, you look at what the chart says, what to do, not to do. A directive gives us guidance, but the MOLST are actually orders. And it's a piece of paper with orders on it that follows a patient wherever they go. So for instance, if we see a patient here in the hospital and the order says, you know, do CPR if the heart stops, well, that piece of paper leaves with them if they go to a facility. Like, let's say they got their hip replaced and now they're going to rehab. That form will follow them there. So if two in the morning something happens, they have a MOLST form that the treatment team knows what to do. So it's orders, and those orders include things like CPR. If your heart stops, do you want a chest pounding and be on a respirator? It includes things like dialysis or antibiotics or IV fluids, IV treatments versus just treatments by mouth. And most of the time they're filled out again in patients in the more advanced end of the spectrum. Again, a healthy 50-year-old doesn't need a MOLST per se. If they're otherwise healthy. It's more when these issues become more nuanced and complicated and, are bound to rear themselves. So,
May I add something?
yes.
Please.
When I discussed it with my physician, my inclination was, no, I don't want intubation. No, I don't want to be resuscitated. And she says, wait a minute. No, I don't want dialysis. And she says, wait a minute. If you're in surgery and your heart stops, wouldn't you want to be resuscitated so that, after the surgery you can live on? And so she put limits on it, resuscitation for 2 weeks or intubation for 2 weeks, that kind of thing. What do you think of that approach?
I think that's rational, reasonable, and understandable. But I think it also shows how the intent of the form, all these things, advanced directives and MOLST, have a good intention. It's to respect the patient's wishes, to make sure they get the appropriate care that they would want. But life's complicated, as you're bringing up. So I understand where your doc's coming from, but what does that mean? Does that mean if, God forbid, you're outside your house and you have a cardiac arrest, now you have to undergo CPR and be in the ICU and be treated in a be treated on a respirator for 2 weeks? So I'm not criticizing your doctor, I'm criticizing the form, because this just exemplifies how medical decision-making is so complicated and dependent on so many variables that we can try to control them for, with forms like this, try to be prepared for the future to avoid certain things or ensure certain things. But life's complicated. It may be clear for certain patients at certain times that dialysis just will not make sense. That's where the form's easy and really works. But for something like you're bringing up, I think that highlights where you sort of scratch your head and, you can write on these forms because they do include paragraph where you can write things. So it may say, perioperatively, just around the time of surgery, I should be full code, but not at other times. But I'm just trying to think creatively, off the cuff. But it shows how the forms are well-intentioned and often helpful, but sometimes tricky.
Now, that's a good answer. Dr. Wilkes, there's a question here from Barbie Wiss. She says, how can I find out how the palliative care group at a hospital such as Suburban or Sibley is organized or functions?
You can ask to, everybody knows us in the hospital, so you could ask nurses or physicians or social workers.
This is Barbara. Can I ask a further question?
Of course,
Yeah.
Go ahead.
So about 7 years ago, and maybe things have changed a lot since then, I had my mother was in the hospital, and I was unfamiliar with palliative care and didn't even know the term. So to avoid a situation, how can I find out ahead of an emergency what it is? It seemed very confusing, and to me at the time as a family member,
Yeah.
and confusing and hard to, so I didn't know what to do. It was just very difficult.
Yeah.
Because I was confronted with a palliative care doctor. I didn't know what kind of doctor he was. I had run into the cardiologist in the elevator the day before, and he said things were looking really good. And all of a sudden I'm told, well, things are not. And it just left me feeling confused, upset, not knowing what to do. So how do I know ahead of time if Sibley or Suburban are my local hospitals? Do I go in? I don't need it right now, but how do I know that it's a reliable and well-functioning organization as far as palliative care goes?
Right. So I just want to make sure I understand your question. You're not asking like, how do you know if a hospital has a palliative medicine service in the outpatient world before you're in a hospital? Or how good is the service that the hospital itself has?
Well, I didn't even, I guess the question is really two-part.
Yeah.
Standing here now, or sitting here now, I would like to know, based on what you've told me about how you interact with different groups within the hospital. And then you said that it could be different within any hospitals. Now you're all part of Johns Hopkins,
Right.
but then you weren't. So going forward, how do I manage that process for myself or somebody in my family, so that I don't run into a palliative care doctor in the hall who tells me what he's decided should be done. And I've never met him, seen him. I don't even know what palliative care is.
Right. Well, you know, palliative care has a branding struggle. What I mean by that is a lot of patients and families, because it's kind of confusing, it's not straightforward, don't understand what it is, and assume it's synonymous with hospice. And that's well researched, that's what families assume. A struggle we have here in the hospital, just to kind of touch on what you're asking about, is a lot of our colleagues struggle with how to introduce the concept to a family without making it seem like it's only for end of life or for hospice. They struggle with that as well. And touching on what you heard before, I mean, just being honest, doctors say things, and sometimes what they say can be unintentionally misleading. Like, oh, your heart's much better. Like, yeah, it's better today than it was a week ago. It doesn't mean it's well, but it's better than it was before. So I'm just kind of thinking about what you're asking. I think one thing you can ask in a hospital is, the palliative service in the hospital, who's on the team? Like I said before, it used to just be me, a doc, but now it's me, a nurse practitioner, and a social worker. And we work with our hospital chaplain. That's something we've always done, but the hospital chaplain is system-wide.
So maybe a better, sorry to interrupt, but maybe a better
Yeah.
way to ask the question that's more general
Yeah,
is if I had a family member in the ICU.
Yeah.
And that's not where my mother started out, but that's where she ended up. And how should I, knowing more than I did 7 years ago, I
Yeah.
would now ask, could you tell me about the services? And I think your idea of meeting the team or who's on the team would be very helpful. I just was unprepared.
Sure.
And I guess I wonder if things have improved over the past 7 years.
Uh,
Or is it still, as you say, it's, each case is unique and it's still very difficult?
I think, again, this is my anecdotal experience in the hospital, but it is true across the country that palliative medicine is growing and it's getting much more well understood, but there's still a lot of mileage to go. But I think for families, if they understand what palliative medicine is already, and you're in the hospital, simply just asking for a consult would be a way to make that happen.
Right. That's very helpful. Thanks.
Yeah.
Okay.
Okay.
Sure.
We're running out of time here, so let's press
okay.
on here. A quick question you can answer very quickly from
Yeah.
Sue. She says, do you recommend mydirectives.com for online record of advanced directives? And I'm sure the answer is going to be yes to that. And she says, I understand that www.mydirectives will show up on my iPhone if I'm I can't quite read it, if I'm in the emergency room. So I think you can answer that quickly. I think it's
Yeah.
yes.
I mean, whatever can make access to them easier is a good thing, assuming it's kept private, of course. But yeah, I can't tell you how often it is. Well, yeah, I have a directive. It's in my lawyer's office. I have to call them. So if there's ways to make it easier to access, absolutely.
Okay, quick question, Stephen,
Yes.
from me. I want to ask you very quickly about, I want everyone here to try, including me, to be pithy because we're running out of time. Medical aid in dying, it's illegal in Maryland. It's legal in
Right.
DC, but not in Maryland. Do you think it will become illegal? And is that a good idea? And is it true that some palliative care doctors like yourself reject the idea that Americans, this is from a new book they call The Inevitable by Katie Engelhardt. You may have read it, but she says in that book that some palliative care doctors reject the very idea that Americans are dying badly and in pain. They argue that advances in medicine allow the pain to be contained so readily now that you don't need medical aid in dying. Any comments on that?
Yeah, can I leave now? No, I'm kidding. So medical aid in dying. So I think palliative medicine doctors are no different than anybody else. It's a complicated ethical issue. Generally speaking, the community, if you want to say that, like our academic organizations, take a neutral stance, saying we don't support it, we're not against it, which is what they've said. I think in Maryland, it's probably going to pass. It's been discussed in committees and several, like maybe 5 times. And I can't remember the last time, maybe 2020 or 2021. And the committee was tied 50-50. So it didn't go the next step to be
lost by 1 vote. Yeah.
Right. So, I mean, probably given the trends in our country, well, who knows what's going to happen in our country, but I think what's been happening is, over time, it's become more and more acceptable and legal. It's legal, and last time I looked, maybe 7 or 8 states.
11 jurisdictions now.
11, right. So I think by now, probably half of the United States, if not more, has access to something like that.
Yeah, it's about 25%. Yeah.
Oh, okay. I thought it was more. Thank you. Did I answer all those questions? I mean,
Yes,
that's
you did.
a whole other topic.
You answered
Okay.
it very well, because what you said was palliative care doctors are different. Some might oppose it, but most people are neutral on it. I work closely with a hospice, Montgomery Hospice, and that's our position there as too. There's a question here, Stephen, from Amy Lamb. She says, how does a patient create a team that involves their family physician, palliative care physician, and hospitalist? My experience, says Amy, with hospitalization has been that to be admitted to a hospital, a hospitalist who does not know the patient needs to become the patient's physician instead of their family physician. So this is a question of hospitalists displacing PCPs. And any comments on that?
Yeah, I can say some extra time, so that's all right.
Thank you.
Yeah, that's a problem in our healthcare system that's become more and more bifurcated. In an ideal world, the primary care doctors contacted and brought into the loop so they can share their wisdom, if they know a patient for a long time. That's helpful. Often what I like about our EMR is that if I speak to a doc, that's great, but there's a whole lot more than you can communicate in 5 to 10 minute conversation. We can just click a button in our electronic medical record and fax whichever records we want to the primary. I think, to brag for Suburban, I think most of the time they're pretty good about communicating with primary care docs. I'll be honest, it doesn't happen for every case, absolutely not. But that's kind of the ideal that my colleagues work towards. And sometimes it's not the primary team, but it ends up being the palliative medicine team reaching out. But you can always suggest, doctors are very suggestible about certain things. If you suggest that, why don't you touch base with the primary doc? She's known the patient for 5 years, 10 years, 20 years. That'll often facilitate that.
Very good. Dr. Wilkes, thanks for that.
Yes.
Very good answer. How do we solve the problem of patients viewing palliative care and hospice care as giving up? And in other words, why are so many patients with a chronic life-threatening illness not receiving palliative care, or receiving it only in the last phase of their illness? And connected with that question is the question of how can referrals to hospice be made earlier so that patients can take full advantage of hospice?
You're hired. Yeah. Look, I think that death and dying or serious illness with implications that may be no longer 10 or 20 years away, but maybe a few years away. That's very hard for most people. Not everybody, but you guys are like way outside of the curve. So I think part of the barrier is just what I talk about as the human condition. Like, most of us don't want to think about death and dying, but some do, some are open to it. So part of it, I think, is just the human condition. The other is, I hate the term, but it's true, marketing. People just don't understand how either service can be beneficial. And there's a lot of misunderstandings. I can't tell you how often I hear, well, if I get hospice, they're just gonna, kill me with morphine or dope me up. Or even in hospice, like, people could be in hospice for months and And for instance, like for heart failure, they continue their heart failure medicines. A lot of people think if you go into hospice, you just kind of stop everything.
Yeah, right.
Just throw your hands up. And, I worked in hospice for 13 years. If the patient's at home in hospice and they're coughing and they have a fever, they can get antibiotics.
Mhm.
Not the same as coming to the hospital with IV antibiotics. So there are limits in hospice, but it's not like you'd say, okay, you're developing a pneumonia. Oh, well, you can prescribe if you want antibiotics and hope for the best. But, generally in hospice, I don't want to mislead people. Generally in hospice, those antibiotics don't work. You're not running to the hospital, but that's why you decided to be in hospice. I'll talk a little bit more about that in a minute, and I think, like I said before, the research has shown that people who say they understand what palliative medicine is, they are thinking what they think it is hospice. So that's really marketing and time and conversations like this, getting the word out so people have a better understanding.
Yeah, that's
The human condition part, but
yeah, that's very good, Dr. Wilkes. It's 4:58. Let me just
Yeah.
ask everybody, Dr. Wilkes has very kindly said he would stay on a bit longer. So if anybody has to slip away at 5 o'clock, we will understand, and don't worry about that, just slip away. But for those of you who'd like to stay on for another, say, 10 minutes, to give a chance to ask more questions of Dr. Wilkes, then Dr. Wilkes, thank you so much for being willing to stay on just another 10 minutes or so.
Sure.
So I've got a question for you about now euthanasia is illegal criminal. It's not it's equivalent to murder. And Dr. Kevorkian, we know that from what happened to him. But I want to ask you about the difference between euthanasia and terminal sedation. Euthanasia is illegal and criminal. Terminal sedation is common and legal, and it happens a lot. But they're both, they seem to me, there's a diaphanous difference between them, a thin line between them. I mean, the motivation is a little bit different, but can you talk to that and talk about how similar they are?
Yeah, I'll do my best. And, frankly, I'm a geek, so I read about this stuff. And, how you define things is a big part of it. So, euthanasia means to alleviate suffering, you're intentionally taking somebody's life. And that can be if they have 6 years to live, 6 months, 6 hours. Terminal sedation, usually what we mean is a patient before you is actively dying, no matter what you do. And the only way to alleviate their suffering under those circumstances is to make them unconscious, because the more alert they are, the more they're suffering. So I think in practice at the bedside, usually something like terminal sedation is when, someone's dying anyway, and you're just making that dying process peaceful so they're not suffering. Even terminal sedation doesn't even necessarily end up with people living shorter. It just means in their final hours, days, they're sedated, so they're not suffering. Now, sometimes in hospice, not in so-called regular medical care, but when people are really in the end of life, meaning weeks to maybe some months, people talk about a vacation where you're put in sedation for a short period of time, hours to days, with fluids, for instance, to get a break from the world. And then it's stopped and you wake up again. That's very rare, but again, people talk about it. I think at the bedside, like in hospice, and again, this is my personal experience having worked in hospice for 13 years. We would be reluctant someone who's got weeks or months, I think we would be reluctant to just make someone fully, deeply sedated where we knew that resorting to that would mean that they would die from that. The ethically tricky part is really about intention. Are you doing it intentionally to end the patient's life, or are you doing it to alleviate their suffering? And an unfortunate consequence of that is that they would die.
Right.
So there it gets kind of nuanced and tricky, but practically in my experience, and that's all I can talk about, palliative sedation to unconsciousness is usually for patients who are actively dying before your eyes.
Very good. That was an excellent answer. Let's see. I'm looking at the chat room. I don't see any more questions there. Did you have more slides you'd like to show us?
Just a few. Let me just quickly. Some of it we've discussed already, but right. So again, I think this isn't so applicable to this crowd, but if you wanted to share it with people, or if you want to delve into it deeper, there is a website, theconversation.org, that has information for families about how to talk about these difficult things. So your loved one isn't guessing at the bedside. There's card games and there's board games, and also just general discussion guidance. And
I strongly support you on that. This group was, as you know, was founded by Ellen Goodman, the Boston columnist, and it's a very good organization.
I hear the card games are fun even, but I haven't done them myself. And just a few of the research on palliative medicine, just to squeeze it in here. It sounds ironic maybe to some, but patients live longer when palliative medicine is involved. At least that's in research with patients with cancer. Obviously improved quality of life and less stress on families, because that's what we focus on alleviating. Palliative medicine is provided in a hospital, outpatient center, where you go in like you'd see any other doctor, or in the home setting. Sometimes it's televisits or actual visits. How to get it, we touched on this. Just ask whoever's involved in your healthcare team. You can, with getpalliativecare.org, if you have families that live in other states, or if you want to know around here what's going on, you can search for providers that way. Again, yes, I've never encountered insurance that said no. So as far as I know, and just to touch on hospice very quickly, because we talked about this already. Palliative care is for patients with serious illness, and hospice is, the final weeks to months. I'm assuming you all know what hospice is. But generally, Medicare defines terminal illness where you can get hospice has a prognosis of 6 months or less. Arbitrary, right? But we need a number. So that's what we chose in our country. So the hospice team, so what I mentioned before is, palliative medicine is a bit amorphous. Some hospitals have full teams with doctors, psychologists, social workers, pharmacists, regular nurses on the team. Some were like here, where it was just me for a while. So hospice is different. For a hospice to be a hospice, it has to provide this team that I'm showing on the slide. You can't be a doc and put up a shingle and say, oh, I do hospice. Hospice, you have to have a doctor, home health aides, social worker, chaplain, and volunteers as part of the team that visit you at home. If you don't have those things, you can't call yourself a hospice. So with hospice, you're definitely getting an interdisciplinary team. Any questions about that?
No, but I just want to underscore kind of your one of your key messages here, Dr. Wilkes, which is that hospice is important and useful, and palliative care is something that people need to pay more attention to and ask for more often. I just want to make, I just want to emphasize that's, that's a key message that I'm hearing from you today.
Yeah, I would agree with that.
It's been a great presentation. Do you have any more slides? Go ahead.
Just, I think a couple more. A lot of people think hospice is a place you go to, and very rarely it is. I worked in a hospice with like 380 patients, and most of them, almost all of them, got that care where they live, whether it's a house or if they live in an assisted living facility or a nursing home. It's very rarely that people go to a place to get hospice care. So in that hospice of 380-ish patients, they have a freestanding facility for patients whose needs become so complicated that they can't be met at home or in a nursing home or assisted living facility. It's very rare. That's the exception in hospice. So this hospice, which had 380-ish patients, had a facility for that and maximum 14 beds. So just to give you a sense, the majority of patients get hospice care where they live.
Sounds like you're talking about Montgomery Hospice. Is that true?
That's correct.
Yeah, I'm on the board.
I heard you say that, right.
Wonderful organization. Yeah,
I agree. So it's just a point I made before, and just some, surprising statistics about hospice. You can see here that yes, it's often acquired much too late. And remarkably, people who get hospice tend to live longer.
Yeah, isn't that amazing?
Some people,
yeah,
but probably because instead of being at home with no one visiting you, you've got a full team of nurses and docs and social workers all looking after you and helping. So
yeah,
it's the opposite of what people assume. So
yeah,
that's it.
Great. Dr. Wilkes, you've done a wonderful job, and you've been so patient answering everybody's questions. Does anybody have any final questions? I'm looking in the chat room. Anybody have any final questions? Kate, you can put everyone's face back on now if you like. Anybody have any final questions before we let him go, before we let Dr. Wilkes go? I'm looking in the chat room, not seeing any, don't see any hands up.
We have Miss Mary.
Oh, Mary Rubino, please go ahead, Mary. Sorry. Thank you.
Hello, thanks very much. This has been a fascinating presentation. I just wanted to ask, you've shared your experience with Montgomery Hospice and the Suburban and Hopkins setups. Are you familiar with Holy Cross Hospice? Could you comment at all about it? Is it similar to the setup at yours, or do you know?
I think so all hospices are similar in that, you have that interdisciplinary team that
Right.
for doctors, social workers, nurses, chaplains, etc. What's unique about Holy Cross Hospice is that they have within a hospital, like I mentioned before, that subset of small number of hospice patients whose care escalates so much, they need hospital level care. They go somewhere like Montgomery Hospice has a freestanding facility, which has around the clock nursing. We call that level of care inpatient hospice. That's just a term, but it's like hospital level care, but it's hospital level care to make sure someone's comfortable, not to do x-rays and CAT scans and all that. What's unique about Holy Cross is they don't have a freestanding facility, but they have a ward in a hospital that patients can go to get that level of care.
Thank you.
Outside of that, I think it's, just like all the other hospices, but, you can Google like Medicare hospices and that lists the hospices in the area and, grades them on their different characteristics. If you wanted more information like that.
Thank you very much.
Yes, thank you, Stephen. Thank you, Mary, for the question. And Rita, you have a question.
Yes, I just have a quick question.
It's 5:12, so
Yeah.
let's try and keep it concise. Go ahead.
Yeah, just
Sure.
a real quick question. Just wanted the doctor's reaction to, I often wonder if your loved one is in hospice at home and then ends up dying there. I just always wonder how that would feel coming back to your home, knowing that this loved one had died there. And that's why I was kind of thinking that it might be not quite as bad for the person to be, in a special ward in a hospital or so
Yeah.
forth. Just
Yeah.
just not having ever gone through that, but I just.
Yeah.
Mhm.
No, it's a good question. I think, I haven't experienced it myself personally, but again, from working in hospice and, helping families with these things, I think, it's a very individual decision. Some families are like, no, it's got to be at home. Dad wanted to be at home and we want to be with dad, be around him. It can't be in the hospital with strangers around. But in hospice, rarely, but sometimes it would happen that when a patient started to die, families didn't want them to die at home because either the reminder would be too hard or whatever meaning they attributed to that event. So hospice would work with them and have them go somewhere else. So
Okay.
yeah.
Thank you.
Yeah, it's a good question, Rita, and good answer, Stephen. And a final note from in the chat room here, very quickly. Lots of thank yous to you, Stephen, from people here, yeah, lots of thank yous to you from people. And then there's a question here. Let's see, from Pleasant says there are some beautiful community end-of-life communities stepping up where you can die in the community if you don't want to be at home or hospital. They have music, food, rituals, etc. Beautiful alternatives. So Pleasant, thank you for that. Okay, I think we're going to bring this to an end. Anybody got any final questions from anybody? I'm looking for hands up or waved hands. Pleasant says thank you. So I want to say first thank you to Stephen Wilkes. Dr. Wilkes, you did a great job. You showed great patience and generosity in sharing your time and expertise with us. We are very appreciative. And I also want to thank Kate McGrell. You can all see her up there on the screen. Can you wave, Kate? There's Kate, who's our key colleague at Suburban. And Kate, thank you so much for all you did to get this event together today. Mary, did you get your hands up? Mary, a quick question. Mary Rubino, did you have a question? Your hands up.
You're on mute.
I'm sorry, I'm on mute and I have no further questions. Thank you all very much for this. It's been fascinating.
Not at all, Mary. So thanks, everybody. We're going to bring this to a halt. Thanks again, Stephen Wilkes. You were great. Thanks, Kate, very much for all your help. Thanks, everybody, for coming. Yeah, just give Stephen a round of applause. He did a great job. Dr. Wilkes, thank you for spending time with us. We all appreciate
Sure, it
it.
was fun.
Take care. Bye,
Bye.
everybody.
Bye.
Thank you.
Bye-bye now. Bye-bye. Thanks.